The Fetal Heart by Derek Kelly,
Michelle Gorzinski,
Naomi Nana.
When evaluating the fetal heart, the first thing you want to do is check that the heart is beating and obtain a heart rate. A normal heart rate is between 120 to 180 beats per minute. M mode should be used in the first trimester, and pulse wave should be used thereafter.
You should always evaluate the position of the heart in relation to the stomach. The stomach and heart should both be on the left side of the body, also known as situs. When you document fetal situs, you should also note the fetal position, such as cephalic, breech, or transverse. A dual screen in the transverse plane can be used for situs documentation. It is important to document situs in order to rule out conditions such as situs inversus, where the heart and stomach are both located on the right side of the body, or situs inversus dextrocardia, where the heart and stomach are located on opposite sides of the body.
As you can see in this slide, there's a four-chamber heart where the right and left atrium, such as the right and left ventricle, are seen together. This can be obtained in the transverse plane of the fetal abdomen. The left atrium is usually closer to the spine, and the right ventricle is most anterior. The ventricle usually have a similar size, with the right ventricle appearing slightly larger than the left due to the papillary muscles. Blood can be seen flowing from the right to the left atrium. A normal for the fetal heart fills 1/3 of the size of the transthoracic area. The septum can be seen clearly as it separates the right and left ventricles and arises from the crus of the heart. The septal view should be obtained perpendicular to the ultrasound beam in order to avoid false positive or ventricular septal defect, or VSD. And the part of the membrane that is close to the crus taper is made of the membrane. So if the angle is poor, it can appear as a VSD.
The outflow tract can be obtained from the four-chamber heart view. The LVOT, also known as the left ventricular outflow tract, can be seen by angling towards the head from the four-chamber heart. You can see the left ventricle and ascending aorta connecting in the image, and the aorta will be coursing in the right posterior direction towards the right shoulder. The RVOT, or right ventricular outflow tract, can be seen by angling further towards the head from the LVOT view and slightly towards the fetal left shoulder. The pulmonary trunk can be seen heading posteriorly towards the fetal spine and divides into the right and left pulmonary arteries.
The aortic and ductal arch can be seen when the fetal spine is up or down, but is best seen when the fetal spine is down. The aortic arch comes from the center of the heart and is seen as it leaves the left ventricle. You can see the three branches coming off the arch in grayscale and color Doppler. These include the innominate, left common carotid, and left subclavian arteries. It has the shape of a candy cane. The ductal arch is the junction between the pulmonary trunk and the aorta together. This is taken in a similar plane to the aortic arch. You can differentiate the aortic and ductal arch by the absence of branching on the ductal. It has the shape of a hockey stick.